Hello, I'm Don Renfrew, and I'm going to be speaking about cough, dyspnea, and pulmonary nodules for approximately the next 45 to 50 minutes. This is a talk of a series of talks about symptom-based radiology. I'm a member of Radiology Associates of the Fox Valley. This is the hospital where I do most of my practice in Door County, Wisconsin. The overlay is the Door County map, and the little red star on the upper right is the town of Sturgeon Bay, where Door County Memorial Hospital lives. In the left side of that hospital picture there is North Shore Medical Clinic. I'm the medical director of the radiology department at Door County Memorial Hospital, and as such I was given the responsibility of running grand rounds. Part of the talks that I gave at grand rounds had to do with imaging and radiology, and what I realized was that many of the family physicians and nurse practitioners, internists, internal medicine physicians, and physician's assistants really wanted some particular instruction on what imaging study to order for what set of circumstances. They wanted that sort of instruction more than they wanted exactly how to interpret an exam, or instruction how to interpret an exam. As a general care practitioner, whether you're a family practice physician or a nurse practitioner or a physician's assistant, you have many options for imaging the clinical symptoms of cough, dyspnea, and pulmonary nodules. At the same time, as a medical practitioner, you want to order the very best test the first time, every time. And for that purpose, I'm going to review imaging of cough, dyspnea, and pulmonary nodules in the following approximately 1 hour period. There are 4 main points that I'm trying to make in this talk. The first point is that when you're imaging the symptoms of cough and dyspnea, your main decision is typically when to order a CT. You pretty much always order a chest x-ray. When do you go ahead and order a CT in addition to the chest x-ray to evaluate cough and dyspnea? For those patients with a cough, your chest x-ray is done first, and then you usually evaluate and treat the common causes of cough before proceeding with the chest CT. For patients with dyspnea, you'll often do the chest x-ray first as well, or almost always. That's going to be followed by an urgent CT if there are red flags for a pulmonary embolism. On the other hand, pulmonary nodules will typically undergo chest x-ray and a CT both, and later on, depending on the symptoms and the condition of the patient and the circumstances of the patient, there'll be a biopsy, excision, sequential CT, or PET CT done. And I'm going to cover those different scenarios in that part of the talk today. Again, so my first point, your main decision about imaging pulmonary symptoms of cough and dyspnea is when to proceed from the chest x-ray to the chest CT. Before I get to that point, I want to review the fact that there are a couple of different exams that you can do, and this is sort of the technique aspect of imaging, if you will. The point here is that unlike the situation with chest pain, where there are quite a few tests you can order, there are probably fewer options when you're imaging cough, dyspnea, and pulmonary nodules. Your standard 2-view chest exam is taken. Typically, the best exam is going to be done in the department. It's going to be done with the patient upright. It's going to be done PA, or posterior to anterior, with the x-ray machine, the x-ray tube on the back of the patient and the film in front of the patient. That reduces the magnification of the cardiac silhouette. Get you a good picture like this one on the left. The lateral is taken with the left side against the x-ray cassette, and the x-ray coming through from the patient's right side. Standard upright 2-view chest shows you the fluid collections at the bottom of the chest. It gives you a good idea whether there's cardiomegaly or not, because the heart shouldn't be more than half the size of the entire chest wall at that level. And it gives you a good idea whether the upper lobe vessels are distended or not. Those are good things about a standard 2-view chest, and that's, if you have the option of having a standard 2-view chest, upright chest in the department versus a portable, you always want to take the option of the standard 2-view chest, if you can just get a better image. The other mainstay of imaging for this particular set of circumstances is CT of the chest. And of course, there are a million CT scanners out there. Most modern CT technology is based on thin cuts of the patient. This has blurred the distinction which was present 10 to 15 years ago between a high resolution or pulmonary parenchymal CT of the chest and a standard CT of the chest. Today's scanners also are able to obtain exams of the entire chest with a single bolus of contrast material, and it gives excellent visualization of all the vessels in the chest, which is critical for diagnosing pulmonary embolism and very helpful for differentiating pulmonary lymph nodes and hilar and mediastinal lymph nodes from vessels. Of course, with the CT scan, you want to use contrast material. Typically, that's injected into the patient with a power injector, and nowadays pretty much everybody uses non-ionic contrast material, which has fewer side effects and is more benign for the patient. The VQ scan I'll mention briefly because for those patients who are suspected to have a pulmonary embolism who cannot undergo a CT study with contrast, either because of renal insufficiency or because of contrast allergy, the nuclear medicine study is your best choice to perform an examination to exclude the diagnosis of pulmonary embolism. Just to remind you, this slide will show you kind of the steps in sequence for doing a pulmonary nuclear medicine pulmonary ventilation perfusion study. You need to take radioactively labeled particles and put them into the patient's bloodstream. Those will then filter out in the lung pulmonary parenchyma, and any area that doesn't get blood flow because it's downstream from a pulmonary embolism will show up as a cold spot, whereas all the rest of the lungs will show up as warm spots, or the whole lungs will be warm. After that, because there won't be any flow to areas that are abnormally ventilated, you also do a ventilation study. If the area is abnormally ventilated, for example, if there's a mass there, or if it's an area of bullous emphysema, then the ventilation study will also be cold in the same spot. Those matched areas are not suspicious for pulmonary embolism. Areas that are mismatched between the ventilation and perfusion study are suspicious for pulmonary embolism. This study used to be done ubiquitously all the time, everywhere, because the next option on the checklist for pulmonary embolism was pulmonary arteriography, which wasn't all that available and was much more invasive. Nowadays, the study of choice for pulmonary embolism is CT angiography, and that's basically replaced ventilation perfusion studies. All right, well, how about image manipulation? One thing that you can do with CT images is that you can do what's called maximum intensity projections, or MIPS, and you can take a slab of data, look at the brightest pixel in that slab, and the big advantage of this is that those vessels that we see in both of these images will look like dots with thin sections, non-MIPS studies on the left, and they'll look like branching tubular structures like vessels when you use a MIPS study with maximum intensity projection of the pixels through a volume slab, as you see on the right. So image manipulation is pretty routinely done in radiology now to help sort out pulmonary nodules versus vessels. If your question is, do I inject contrast, do I not inject contrast? If the opportunity exists to inject contrast when you're doing a CT, inject contrast. It will show you much more information than the non-enhanced study. Exceptions to that rule include, number one, if the patient has renal failure, has a high creatinine or elevated creatinine or increasing creatinine. Number two, if there's a personal history of contrast reaction with that patient. Of course, you have to make sure it really is a contrast reaction and not simply hives or vomiting with prior administration of contrast. And then number three, if you're simply following a pulmonary parenchymal nodule that is nowhere near the hilum or mediastinum, and there's no possibility of confusing that nodule with a vessel, and you already seen that nodule on a prior study, and all you're doing is following that nodule, you don't really need contrast to do that. Now, one of the advantages of using a CT scanner instead of a chest x-ray is that it does show you distinct different information, and typically much more information than the regular x-ray. Here we have a 53-year-old who had pain after trauma. And again, although this lecture is on cough, dyspnea, and pulmonary nodules, this patient did have some dyspnea along with his pain and trauma history. And this is a standard chest x-ray. If you blow up the chest x-ray, you can appreciate that in the right lung apex on our left, the lung markings do not go all the way out to the lung periphery. On the left that they do. And this arrow emphasizes that fact. Here we are with an inverted image. Sometimes it's a little easier to appreciate the fact that the lung markings don't go all the way out with an inverted image. and again, an arrow delineating the area of the lung with the decreased lung markings. Here's an expiratory chest x-ray, and sometimes the expiratory chest x-ray will crowd the lung markings and allow you better visualization of the pneumothorax, although carefully done studies have shown not a whole lot of difference between the actual accuracy between inspiration and expiration chest x-rays for detection of pneumothoraces. Here again, an arrow noting the absence of lung markings in the periphery of the right lung. Now compare that picture with this picture where you see the lung parenchyma and you see a very black and very obvious area where there aren't any lung markings and there is no lung, and that indicates a pneumothorax along the anterior chest wall here as noted by the arrow. So you can see that on the CT it's much easier to see the pneumothorax than it is on the plain film, and indeed it has been proven many times that small pneumothoraces you can see on a chest CT that you cannot see on plain film exams. Here's the cause of the patient's pneumothorax. In this case was this sort of jagged rib fracture shown by the arrow along the posterior upper right chest wall. And there again, in retrospect, if you look back on his chest x-rays, you can see that rib fracture as a cortical interruption on the inferior surface of the right third rib marked by the arrow. Here's a composite picture of the points made here, and that is that expiratory chest x-rays sometimes allow you to see a pneumothorax that you can't see on an inspiration view. The CT shows you that pneumothorax much easier, and then in this case, the pneumothorax went away after a chest tube insertion as shown in picture D. So again, the point with cough is that a chest x-ray is done first. Then you follow that, usually with evaluation and treatment for the common causes of cough. Now, what is a chronic cough? What is an acute cough? Arbitrarily somewhat, the cutoff has been put at 3 weeks. You can divide those patients, or you can divide patients generally into those with an acute cough, which is less than 3 weeks duration, and a chronic cough of more than 3 weeks duration. Patients with an acute cough, especially when it's accompanied by a febrile illness, or a productive cough, will usually have a chest x-ray to identify consolidation, which can be indicative of pneumonia. So in rare cases, a radiograph may demonstrate a surprise, an unpleasant surprise in these cases, such as a pulmonary mass. The patient may still have pneumonia if they develop the pneumonia upstream from the mass in an area of lung that's not normally drained or ventilated. These patients will usually require a CT exam. And you're going to look not only for the mass, but also the consolidation upstream from it, and you're going to look for synchronous malignancy elsewhere in the lung, and you're also going to look for hilar and mediastinal mets. Here's a 34-year-old with a pretty straightforward clinical history of cough, fever, and dyspnea. This is a case with acute cough. Same lady before she got the cough, fever, and dyspnea done for another indication some year or two before her present symptoms began. And here side by side you can see consolidation with increased lung density on in the right lung on the left side of the picture on the right. Occasionally pneumonia may be occult. We learned this basically during the early HIV era when a lot of patients we strongly suspected had pneumonia but were showing up with negative chest x-rays. CT was, becoming more readily available at about that same time. These people were frequently CT'd, and you could often see pneumonia on a CT scan that you could not see on the chest x-ray. So radiographically, occult pneumonia is a known phenomenon at this point. This 78-year-old woman had cough, syncope, and weakness and came into the emergency room. She subsequently had a CT study done because the suspicion was that she may have had a pulmonary embolism in addition to the or instead of pneumonia. The CT study showed no pulmonary embolism, but what it did show was an area of consolidation in the left lower lobe, noted by the arrow here, and that area of consolidation was considered to be pneumonia because the patient did have some fever and a white count, and and her symptoms relented with antibiotic treatment. So here's a composite picture of the chest x-ray, and again, it's very hard to see that pneumonia, even in retrospect, even knowing exactly where it is on the chest x-ray, whereas you can see it pretty clearly on the CT study. As far as red flags go, there are several red flags which you should probably provoke you into ordering an earlier chest X-ray and a CT scan. And these include symptoms such as hemoptysis, chills, weight loss, fever, and smoking. With respect to smoking, note that most smokers know what a smoker's cough is if they have it. And they won't really come to the doctor saying, "Doctor, I have a smoker's cough," because they've had it all along, they know what it's from, they know what it's like. If you do have a smoker that comes to you and tells you that they have a cough, the main question to ask her is if that cough is new. If their cough is new or has changed character significantly and they're a smoker, that probably requires a pretty vigorous workup, because you want to make sure that they haven't developed a malignancy because of their smoking on top of their already known chronic bronchitis, or if they have a new pneumonia because of their lung disease associated with smoking, and that's producing the new cough. As an example of patients with red flags, here's a 68-year-old man with hemoptysis. On this two-view chest exam, you can see that he has abnormal opacity in the medial left lung apex, compatible with consolidation. He also has a hilar mass in the same lung, and in addition to that, he has abnormal density in what's called the anterior clear space between the root of the aorta and sternum, where there's usually just nothing but lung tissue. There's something dense there producing a white blob of tissue. On the axial CT scans, we see abnormal opacity in the medial left lung alongside the aortic arch here, noted by the arrow. And then more inferiorly in the chest, he's got not only lung consolidation / mass here, denoted by the more anterior arrow, but he also has a lump of tissue alongside this pulmonary vessel, which is very suspicious for metastatic deposit into a node that's draining the tumor in his left upper lobe. And here's a composite picture of this unfortunate gentleman with hemoptysis who proved to have adenocarcinoma that shows the consolidation, the more central mass, and the metastatic deposit. Now, so that's acute cough. So you've got acute cough. If they have any of those, danger signs or warning signals, you want to obtain an earlier chest X-ray, an earlier CT scan. What about chronic cough? Well, chronic cough is a little different. Remember, chronic cough is more than 3 weeks duration. And chronic cough typically is traced back ultimately to one of 3 diseases. Postnasal drip, gastroesophageal reflux disease, or GERD, and asthma. In patients with chronic cough, a chest X-ray will usually be obtained, although it's usually going to be normal because these 3 disease processes don't really produce much in the way of symptoms, typically. Therefore, diagnostic algorithms will typically call for a careful review of systems in patients with chronic cough to elicit any subtle findings or subtle history of any of those 3 diseases. And then you'll do further diagnostic testing in those cases where there are suggestive symptoms. If there's some heartburn, postprandial pain, if there's some tickling in the back of the throat, these of course are respectively GERD and postnasal drip symptoms, then you probably want to chase down, what exactly, whether those patients have any other imaging or clinical findings or laboratory data that would suggest one of those 3 symptoms. Specifically, if you think somebody's got postnasal drip, a sinus CT can be helpful. If you think somebody has gastroesophageal reflux disease, pH monitoring can be helpful. If you think somebody has asthma, then spirometry or methylcholine challenge test can be helpful. If you have the patient and they don't really have any of those symptoms, then your possibilities include going through all those tests, which is a lot of tests, or trying to guess which of those 3 it's most likely to be. The other alternative in terms of taking care of these patients is, instead of testing them for all 3 of those different entities, if they don't have much in the way of specific symptoms, is to sequentially treat them for each of those entities and see how they respond. Do they get better with bronchodilators? Then they probably have asthma, and you keep them on the bronchodilators. Do they get better with H2 blockers? Well, they may well have GERD. Do they get better with nasal glucocorticoids or antihistamines and decongestants? Postnasal drip. So that's how that all kind of fits together. At some point in the evaluation process, usually after everything else has failed, although sometimes abnormal. If there's an abnormal chest x-ray, you want to probably get a CT, or at least you can get a CT. Unfortunately, CT studies provide clinically meaningful information in a minority of cases, maybe 1 in 6. Helpful findings that you could see on a CT include bronchiectasis, an unsuspected tumor, or maybe interstitial lung disease. Now, regarding interstitial lung disease, there have been volumes written regarding the radiographic appearances of the literally dozens of diseases that fit into this category. And from a radiologist viewpoint, the best summary I can offer is that while the CT findings are almost always, there are usually CT findings there, but they're almost always non-specific. So sometimes combinations of the imaging features allow reasonable differential diagnosis or even fairly specific diagnosis, but in the end, because treatment is prolonged and the diagnosis is very important to make as certain as you can, in the end, lung biopsy is often necessary to unequivocally secure a specific diagnosis. The CT scan will show you whether there's not any interstitial lung disease there. Typically, a negative CT scan pretty effectively rules out interstitial lung disease in most cases. Finally, in patients with chronic cough, note that about 10 or 25% of patients with chronic cough, despite all the diagnostic testing that you do, may have an unclear cause. You just may never know why some people have chronic cough. So for patients with the cough, you do the chest x-ray first, then you follow with evaluation and treatment for those common causes. Then you do the CT somewhere along in there, looking for interstitial lung disease and other unusual causes, and at the end of the day, you may still be frustrated as to the true cause of that cough. But at least you know what imaging studies to order and when and how to order them and what to expect from them after this piece of the lecture. Now what about dyspnea? Here's a 53-year-old man with dyspnea and chest pain, and it's clear the cause of his dyspnea is this large pneumothorax of the right lung. You can tell that the lung is retracted down. There's air all the way around the lung marking, or the lung edges are marked by the arrow, and then this dyspnea and the pneumothorax resolved rapidly with placement of a chest tube and re-expansion of the lung. Here's another case of dyspnea in a 33-year-old, and in this case the chest x-ray showed focal areas of abnormal opacity in the right lung in 2 different spots, and a follow-up study after treatment with antibiotics shows clearing of those areas. And this patient also had, in addition to dyspnea, fever and some chills and a high white count, and clearly had pneumonia. Finally, this chest x-ray obtained in a patient with dyspnea showed abnormal density in the right chest, cardiomegaly, pretty fat pulmonary vessels, and a pacer indicating cardiac disease of some kind in the past. A previous chest x-ray, shown on the right side of this slide, shows that those right lung findings were much less pronounced and their lungs were much less dense. And of course, this finding is going to represent pulmonary edema from congestive heart failure, which again cleared after treatment. So those are a couple of causes of dyspnea, which are diagnosable on the plain film and show obvious plain film abnormalities. Here's a 74-year-old woman with dyspnea that came into the ER with severe dyspnea and some chest pain, and a chest x-ray that didn't really show too much. Her CT scan, obtained because of a positive D-dimer and a strong clinical suspicion of pulmonary embolism, showed pulmonary emboli in the pulmonary arteries. These are shown as filling defects in the contrast column. Here's a label diagram showing the pulmonary artery, aorta, pulmonary emboli in the pulmonary vascular tree. So again, for patients with dyspnea, you do the chest x-ray first. You do that urgent CT if there are red flags for pulmonary embolism. Those red flags are usually, you're usually going to find those out because the patient's basically in the emergency room with severe shortness of breath and or chest pain. Of course, they can have a positive D-dimer, which is often helpful in the emergency room or outpatient setting. It's not as helpful in inpatient setting because there are a lot of things like recent surgery that may cause the D-dimer to be elevated in a false positive fashion, at least false positive with respect to pulmonary embolism. All right, that brings us to our last topic, which is going to be pulmonary nodules and masses. And pulmonary nodules and masses will undergo usually chest x-ray and CT. And those studies may be followed by biopsy, excision, sequential CT, or PET CT scans, depending on the situation, the circumstances of the patient. And broadly speaking, you can divide these patients into 3 categories. Those who are symptomatic, with their mass or pulmonary nodule. These are the minority of patients. There are very few patients that actually present in that fashion. There are patients with a known malignancy where you know that they have breast cancer, colon cancer, thyroid cancer, some kind of cancer, and you find a nodule in those patients and you already know they have a known primary tumor. And finally, there is a large category, and growing even larger now with the ubiquitous use of imaging, of those patients that have incidentally found lesions. So what about pulmonary nodules or masses that are symptomatic? Again, you'll see very few of these patients in your entire career because almost all pulmonary nodules and masses are not symptomatic. But when you do see one, it's usually an interesting case. Here's a 34-year-old woman with chest pain who had a PA and lateral chest examination done. The PA chest exam showed a mass in the left upper lung. Now, a 34-year-old woman, it's very unusual for a cancer to develop in a 34-year-old woman, and it's very unusual for a cancer to cause pain as a pulmonary mass unless it's eating into the pleural space or a rib or something. So the next step, of course, when you see something like this is to get a CT to find out exactly what's going on. In this case, the CT showed this lesion in the left upper lobe, marked by the arrow here, and note that that lesion shows the same density on this contrast-enhanced study as does the vascular tree. This is an intensely enhancing, it's actually a completely vascular lesion. This turned out to be an arteriovascular malformation on this coronal study. You can see the contrast coming into the lesion from the hilum. It's a huge feeding vessel into this thing, and there's also a huge draining vein out of it. And basically, this is a huge AVM causing so much flow that it was causing the patient pain. This arrow delineates the lesion itself. In this case, we did a perfusion study, not to see if there were filling defects in the perfusion study or cold spots, as I was talking about earlier for pulmonary emboli, but actually to see the extent of shunt. As you recall, what I told you before was if you put radioactive material in a vein that's in a large particle form in the ventilation perfusion study, that all should get filtered out in the lungs, and the lungs will show up as hot. If you have an arteriovenous malformation, there's no capillary bed in the malformation, and the material will go straight from the vein through that AVM back into the systemic arterial circulation. And you can calculate what shunt percentage there is, and this is a study where we did just that for this patient. A low shunt percentage, like 2 or 3%, indicates that that's probably not going to be a very significant problem for that patient, even though it still may need to get fixed. A shunt percentage of 24 at rest, which is what she had, shows that there's a lot of blood going through that particular AVM. And as those things grow and get bigger and parasitize more blood flow, it's only going to get worse for her. Because of that, she had an embolization of this. The embolization was performed with a radiodense material. So you can see in the upper lobe, where before she had a lesion, this is actually a contrast-enhanced exam, so the vessels are kind of gray at this particular window and level setting. The bright white stuff marked by the arrow is the embolic material plugging up her AVM. Her shunt percentage went way down, and she got much pain relief after embolization of her arteriovenous malformation. That's a little bit of an unusual cause. Much more frequently, you're going to have a known malignancy, and you're going to want to follow that. Now, a lot of times these patients will be seen by the oncologist, and the oncologist will order the imaging study. But sometimes family medicine physicians or nurse practitioners will see the patient for some unrelated symptom, even though they are known to have cancer, or even if they had treated cancer in the past, and you end up obtaining a chest x-ray, you'll find a lesion on there. Most of the time, most studies have shown that CT is considerably more sensitive and accurate for detection of pulmonary metastatic deposit, and also bony mets and other problems in the chest of that nature in a patient with known primary tumor. So the chest x-ray can be kind of a screening test. CT is probably a better screening test. In this patient, he had, unfortunately, both breast, believe it or not, and prostate cancer, and he was undergoing evaluation for metastatic deposit. He had a chest x-ray. On the chest x-ray, there's a subtle area of opacity in the right upper lung marked by this arrow, just under the clavicle there. On a CT scan, this is a coronal reconstruction of the CT scan, and the arrow marks that lesion. As you can tell, there's some more lesion underneath that lesion that wasn't really easy to see on the chest x-ray. Here's a cross-sectional image through the superiormost lesion in the right upper lobe. This is a cut that's done more inferiorly on the patient and shows additional abnormal lung density compatible with tumor. marked by the arrow. And finally, this poor gentleman even had mediastinal nodal metastatic deposit in these prevertebral nodes behind the right pulmonary artery, marked by the arrow there. The soft tissue densities are abnormal metastatic deposit in lymph nodes at that location. Here's a composite showing his chest x-ray. Again, subtle disease on the chest x-ray, easily seen on the CT, and you also see the nodes in the mediastinum on the cross-sectional CT marked D here that you have no way of seeing on the chest x-ray. Again, the story there is for known malignancy, chest x-rays are okay, they're a screening study, CT is going to show you more disease and show it to you better. That leaves probably the largest category nowadays, which is incidentally found pulmonary nodules and masses. And in turn, these incidentally found lesions fall into three kind of categories. One of which is those pulmonary nodules and masses that have distinctive features where you can make a specific diagnosis on the basis of imaging without the necessity to go further. And then there's those those incidentally found lesions where you can use time to distinguish between what you need to work up further and what you can leave alone. Finally, in those cases where you can't figure out from any distinctive features and you don't have the benefit of time or can't wait, you end up doing either PET CT scans or biopsies to figure out the final answer. So let's talk first about distinctive features that you may see on a CT scan or plain film that would allow you to make a specific histologic diagnosis or at least avert any further and more expensive workup. Here's a patient with an incidentally discovered pulmonary nodule in the right upper lung. She was having a chest x-ray done for some other reason. This exam was done, as it says on the date there, 1507. On an additional study, 72009, the right upper lung nodule seemed to be more conspicuous. So there's the nodule on the 72009 image marked with an arrow. And here's the two studies side by side. On the left is the earlier study, and on our right is the later study. And that nodule certainly seems to be getting more conspicuous through time. So we've got to worry that this is a growing metastatic deposit or some sort of lesion that's picking up steam through time. We did a CT on this patient, and this particular lesion was densely calcified throughout the entire lesion. It's marked there, and we measured it, and no matter what the window and level setting was, it was almost as dense as cortical bone. When you see a lesion like that, it's almost certainly a granuloma, and there's no reason to either further image it or to biopsy it or to do anything with it other than to call it benign granulomatous disease and move on. Here's a coronal image of the same lesion. And here's our composite showing the earlier chest x-ray, the later chest x-ray, the coronal CT, and the axial CT study. Here's a more interesting case. You see granulomas, calcified granulomas quite frequently in radiology, and they're pretty much ubiquitous in the upper Midwest, particularly histoplasmosis is in the soil, and you'll see almost everyone has calcified granulomas in their lungs. In other parts of the country, other parts of the world, the same kind of granulomas would only be seen with tuberculosis. But regardless, it's a benign disease and not indicative of malignancy. Now, how about the 74-year-old woman with an incidentally discovered chest lesion? She was having a total knee or heart failure for some reason. I can't remember exactly why she had this particular chest x-ray, but she has a round mass in the right base. This lesion underwent CT scanning here. Now, because it wasn't clear what that lesion was, it ended up being biopsy. You can see the biopsy needle coming in from above the patient, and the needle tip is in the lesion. There was some controversy initially about whether the biopsy specimen was adequate or not, because the pathologist said, well, I just see a large amount of cartilaginous tissue and some fat. And I went back to the CT scan, blew it up, and looked carefully in the interior of the lesion, and the interior of this lesion, which is denoted here, actually had fat within it. It's a very unusual finding for a tumor in the lung, but it is diagnostic of a hamartoma. So in retrospect, if we had known what we knew at the end of the day when we first started out in this evaluation and that this lesion had fat in it, we probably wouldn't have needed to biopsy it. We could have probably just safely followed it. But in this case, it was biopsy proven to be a hamartoma. and some further CT images show the lesion there. Here we have kind of a composite of the diagnostic chest x-ray that was done, showed the incidentally found lesion, and then the CT studies showing initial and then a follow-up exam showing a stable lesion over a period of time, and the CT study showing a fat density on the inside of the lesion. As fortune would have it, between the first time I looked up this case or found this case, diagnosed this case, and the first time I gave this lecture some almost 2 years later, this patient had some trauma to her chest wall and came in for a chest x-ray in the ER. It's like the day before I gave the lecture, and she had another follow-up chest x-ray, and the lesion looked just the same, so it's stable through time. Again, indicating that it's a benign lesion. Now again, I've referred multiple times to this time issue, and in addition to, or instead of, specific benign features on imaging such as calcification in a typical pattern for granulomatous disease, or fat, indicating a hamartoma, we can always look backwards or look forwards at images to try to tell whether the lesion is stable through time. Of course, your best bet, if you have a new lesion, or if you have a lesion on the chest x-ray or image that you're looking at, is to try to find any old lesion, or I'm sorry, old examinations, to see if that lesion may have been there before and stable through time and thus established as a benign lesion. Here, for example, is a 72-year-old with a very dense lesion in the right lung, almost certainly a granuloma, didn't have any old chest x-rays. There's the lesion, marked by an arrow. She did have, however, an abdominal CT scan done some 2 or 3 years before, and the scout view of the abdominal CT scan actually included the lung base. The scan didn't include the lung base, but the scout view did. And if you look at that scout view, the CT scanogram shows a lung nodule in the right lung base, right there where the arrow is. And so looking at the regular x-ray and the CT scanogram side by side, you see the nodule marked by the arrows here as being exactly the same, it measured the same, it looked the same. You can safely forget about this nodule. It's certainly, almost certainly calcified, and it's certainly not changing over a 2-year period. Typically, 2 years of absolute no growth is taken as the characteristic feature of a benign lesion. There is that's sort of embedded in the literature and tradition, and it's not absolutely fail-safe, but generally speaking, if something's stable over 2 years, people assume it's benign and kind of move on. Of course, if you don't have the luxury of old exams and prior studies to compare to, you may be forced to look forward in time rather than look back in time, and to take your patient and follow them through time to make sure that the lesion grows no bigger, and if it does grow bigger, to do something about it at that time. Now, unfortunately, the exact follow-up pattern of when you do that examination in follow-up of a found incidentally discovered nodule is very, it varies in a way that's complex and difficult to memorize. But this table, which is pretty widely publicized and from the eminent Fleishner Society, and was published in many other places in addition to Radiology in 2005, which is our main journal, gives you the following rules. If you've got a small nodule and you have no asbestos exposure, smoking, or known malignancy, then your best bet is just to ignore that. If it's 2 or 3 millimeters and the patient doesn't have any cancer, those are almost entirely benign granulomas, and you're really causing more trouble than you're solving if you pursue those. So those really small nodules in such patients you can ignore. If the patient does have a history of smoking or asbestos exposure or a known malignancy, and they have 2 or 3 small 2 or 3 millimeter nodules, two or three separate 2 or 3 or 4 millimeter nodules, then you can do a CT in 12 months, and if they're stable at that time, you can forget about further imaging. If they're 4 to 6 millimeters, as it notes in this table, you can do, and the patient doesn't have any risk factors, then you do a CT at 12 months, and if there isn't any change, you stop. And you notice one characteristic of this table is it's kind of kitty corner. For smoking and asbestos exposure, you just kind of bump things up a notch. So if you're greater than 4 or somewhere between 4 and 6 millimeters and you do have the personal history which suggests you might have a malignancy, then instead of waiting 12 months to examine again, you do it at 6 months. And then if everything's stable between the 0 and 6 month exams, then you repeat that in 24 months. As you might guess, if you don't have a smoking history and you got a nodule 6 to 8 millimeters, then you're going to do the same thing as you did with the smokers, etc., when they had 4 to 6 millimeter nodules. And you can kind of look at the rest of the table. Basically, as the nodules get bigger, you shorten the interval you examine them, you bring them back for more follow-up exams, you get more aggressive in their workup, you do more studies, or you do more PET scans. And PET scans or positron emission tomography scans are done basically by injecting radioactive glucose into the patient. And glucose, of course, is taken up and burned by any metabolically active tissue. What you want is the patient to be absolutely quiet and relaxed so that their muscles aren't burning glucose, and you want them not talking so that their vocal cords aren't burning glucose. Unfortunately, you can't make them not think, so their brain's going to burn glucose. But other than the myocardium and the brain, usually on a PET scan, all is pretty quiet. And if you see hypermetabolism in a pulmonary nodule, that's indicative of possibly malignancy, possibly infection, but certainly something that's abnormal. However, small nodules are under the resolution of the PET scan, so for those smaller nodules, you really need to do the CT scan sequentially. Your nodule usually has to be 8 or 10 millimeters before you can get a real good look at it on a PET scan. So here's a 61-year-old woman who had an incidentally discovered pulmonary nodule, and this may look familiar because this is the same example I showed you on the MIPS earlier. There's a peripheral lung nodule found on an exam from 6/14/07. There's an arrow on that nodule. Here we are on 12/21/07. Nodule looks pretty stable. Here we are in 8/25/09. Again, nodules are nice and stable. Here's a composite picture. The white arrows are actually on vessels, proving the point that, vessels do look like nodules if you don't have MIPS. And the black arrow is on the stable subpleural pulmonary nodule that didn't show any change for 2 years and was at that point deemed benign, and the patient given a clean bill of health and let go. So the other issue is in those patients that have a nodule that's more than 8 millimeters or somewhat worrisome, what's the next thing that you can do? Here's a 63-year-old woman with pneumonia, and you can tell that she has increased density in her right lung apex here. She had a cough, she had fever, she had consolidation, she's got pneumonia. That's all we really need to know, except over here on the contralateral side, there's also an additional lesion. On the cross-sectional CT scans, you can see the consolidation in her right lung apex, denoted by the arrow here. In the contralateral lung, way up at the apex, there's a small, spiculated, very worrisome-looking lesion. Now, this lesion's over 8 millimeters, and in a woman of this age, depending on her exact circumstances, you may choose to follow it, but that looks very nasty. It looks like it's spiculated. It looks like it could be something bad. So we chose to go ahead and pursue this with a PET CT scan. And again, the PET component of those exams are very low resolution. They're just blobs of activity where there's hypermetabolism. Note that the hypermetabolism in this case is in the left lung apex, marked here by the arrow. And that's a bad thing. And when you have hypermetabolism in a nodule of that size, it's almost certainly malignant. It could be inflammatory, but almost certainly malignant. And because this patient wasn't the greatest surgical risk in the world and they wanted a tissue diagnosis before proceeding to surgery, we went ahead and biopsied this. And here you see the needle in the lesion from a posterior approach with the patient kind of flipped over and on her belly. That arrow marks where the lesion and the needle are. And this came back adenocarcinoma, and the patient went on to surgery. Here's a composite showing the pneumonia, the contralateral incidentally found pulmonary nodule, the spiculated mass, spiculated nodule in the lung apex, the PET scan, and the CT study. So again, to review this kind of the most complex topic we've covered today, pulmonary nodules and masses undergo a chest x-ray. They'll usually undergo a CT as well. And your workup of them depends on whether they're symptomatic, whether there's a known malignancy, or whether they're incidentally found. Even the incidentally found ones kind of break down into those that are those that have characteristics that allow you to stop the workup at that point, those that you can evaluate through time, or those that you need to proceed more directly with PET CT or biopsy. So again, the whole talk reviewed cough, dyspnea, and lung nodules. And your main decision for cough and dyspnea, when you go from the chest x-ray to the CT scan, and in those patients with a cough, of course, your chest x-ray is done first. Again, you evaluate and treat those common causes of cough, postnasal drip, GERD, asthma. You evaluate, careful review of symptoms, possible trials of treatment for those three things. CT, probably later rather than sooner, unless there's some red flag triggering you into it. For patients with dyspnea, you get the chest x-ray. You want to get the CT very soon or right away if there are red flags for pulmonary embolism like severe shortness of breath, severe chest pain, pleuritic chest pain, positive D-dimer. And again, with the pulmonary nodules, they have to undergo sort of a sequence of exams. And that's the end of this talk. Thank you very much.